Okay. Um, Drug therapy for diabetes, chapter 17. Okay, so the blood glucose control. So when you're looking at diabetes, you're looking at blood glucose control. And hold on, just you're looking at blood glucose control. Let me just get my slide here. Okay, so blood glucose control. Um, so glucose is a sugar-based nutrient that is critical for emergency production in the cells and also the organs. Insulin itself is a protein hormone produced by the pancreas that binds the insulin receptors on many of the cells. So like hormones, insulin is a key um, that binds the receptors that or locks the receptors. So when insulin binds to its receptors, the doors on the cell membranes open for glucose to enter these cells, which lowers the blood glucose levels. So glucose in the cells undergo metabolism to generate the cellular energy needed to perform all functions, particularly, organ physiologic functions. So when you have that blood glucose levels, when they're lower than normal, this is when the patient presents signs of hypoglycemia. So glucose is not available for cells and organs to actually metabolize it into energy, substance, and cellular functions can be greatly reduced during that time. However, too much glucose leads to many serious complications, such as what we call diabetes mellitus or DM. So, good glucose control, sometimes called the glycemic control, requires balancing blood glucose levels. So, levels are constantly in the normal range, um, and um, and and um, and this is what we want to do. So you have certain laboratory tests because you want to make sure that anybody that's going through the hypoglycemia or diabetes or patients who have been diagnosed with diabetes, they're going to have certain laboratory tests, and then we have certain goals when they do have these laboratory tests. Exactly what we want to see. So one of the laboratory tests and your most common ones are your fasting blood glucose levels and your hemoglobin A1C levels. So your fasting blood glucose, the indications for good blood glucose control is less than 100 or 5.6 um, ml or 5.6 ml liters. So basically, control levels for older adults usually increase by 1.0 milligrams per DL for every decade of life. So when the patient is doing the fasting blood glucose levels, those are the goals. This is what you want them to look for. Then you have your glycosated hemoglobin A1C, also known as the hemoglobin A1C. The aim for that one is anywhere between 4% to 6%. Okay. So when we think about blood glucose control, you looking at the pancreas itself. So the pancreas is, we always want to say, consider looking at the norm. So the healthy pancreas, it controls the blood glucose levels through the actions of insulin and other hormone, glucagon, or through other hormone and also glucagon. Um, so your insulin, it prevents elevated blood sugar, such as hypoglycemia, by allowing blood cells to take up and use the stored carbohydrates, the fats, and also protein. It is known as the hormone of plenty because it releases or release, it's triggered by high blood glucose levels. Then you have the glucagon. It's a hormone that has actions opposite of the insulin. And it prevents low blood glucose levels by triggering the release of glucose from storage sites such as in the liver and also the skeletal muscles. So that glucagon is known as the hormone of what we call starvation because the trigger for its release is lower than normal blood glucose levels. So when these two hormones are released appropriately, blood glucose levels remain within that normal range. So you want to remember this, especially when it comes to your memory jogger, about the insulin and also about the glucagons. Okay, about insulin and also about the glucagons. So insulin again is the normal of it's the hormone of plenty, which is released when the blood glucose levels are above normal. The insulin is going to be released. Again, it's the hormone of plenty. So its function is to basically lower the blood glucose levels and prevent hyperglycemia. Then you have your glucagon, and glucagon is the hormone of starvation, which is released when blood glucose levels are lower than normal. Its function is to raise blood glucose levels and prevent hypoglycemia. And prevent hypoglycemia. Okay. So in addition, that's just kind of a brief overview. So when you look at the loss of glucose control, diabetes mellitus itself, diabetes mellitus is a common chronic endocrine problem in which either the lack of insulin or poor function of insulin impairs the glucose metabolism. So when glucose metabolism is poor, problems in fat metabolism and protein metabolism that begins to occur. So when there is not enough of insulin or when insulin does not bind well to the receptors, the glucose does not enter cells and circulates unused and high levels basically in the blood. So the main feature of the DM or diabetes mellitus is chronic high blood glucose, which is hyperglycemia because the glucose movement from the blood into the cells and the organs that actually becomes impaired. So again, you as a memory jogger, the main feature of diabetes mellitus is the chronic high blood glucose levels, hyperglycemia, because the glucose movements from the blood into the cells and the organs is going to be impaired. So when it comes to another memory jogger, you always want to know your signs and symptoms of hyperglycemia. So the early signs would be frequent urination. Your patient will probably present, voice that to you. Increased thirst, dry mouth, blurred vision, fatigue, headache. Late signs would be fruity smelling breath, abdominal pain, nausea and vomiting, shortness of breath, weakness, confusion, and coma. So just make sure you kind of highlight that in regards to the memory jogger and in regards to, for hyperglycemia, early signs and also late signs, okay? And, a lot of people, at least your book states that at least 29 million people in the United States and 2 million in Canada are living with diabetes mellitus. Nearly 1/3 of people with diabetes have not been diagnosed and are not being treated. And then another 90 million have pre-diabetes, which is abnormal glucose metabolism that has a high risk for developing into actual diabetes mellitus. So you're going to have two categories when it comes to diabetes mellitus. you know, we spoke about when I teach in maternity, we spoke about diabetes that can occur with pregnancy, such as gestational diabetes. And there are two main types of diabetes mellitus. So you have type 1 and you also have type 2. When it comes to type 1, this is an autoimmune disorder in which the beta cells itself of the pancreas that store and release insulin are destroyed when the person's own immune system takes destructive actions and produce antibodies against the insulin secreting the cells in the pancreas. So this immune attack can be caused by a genetic predisposition or even exposure to a certain viruses. So the most common begins after a viral infection, such as if the patient had mumps. We have another one called the Coxsackie virus or Coxsackie virus infection. And diabetes mellitus 2, when it's diagnosed, is usually diagnosed during childhood, especially with teenagers. They may present signs during that time, and also it also has been noted that a child is it can happen before a child is even 1 year old. Other names that you might hear when it comes to diabetes or DM type 1 are insulin dependent diabetes mellitus or juvenile diabetes mellitus. With type 1 the pancreas actually produces no insulin at all, and the patients must take insulin daily for life unless a pancreas transplant is actually received. Do you have diabetes type 2? And this is a disorder in which the person continues to make some insulin, but it does not bind well to its receptors. So there is a reduced response of the body to the insulin, known as insulin resistance. So eventually the pancreas makes less and less insulin. When it comes to the insulin resistance, develops from obesity, decreased physical activity in people who have been genetically predisposed. Obesity is mostly common, but not with all type 2 patients who have diabetes mellitus. And also diabetes mellitus type 2, and during adulthood, children have been known to actually fall into that category of being diagnosed with diabetes type 2. Okay, and sometimes you may hear names as when you're working in a clinical setting, instead of diabetes type 2, you may hear non-insulin dependent diabetes mellitus, which is also known as NIDDM, or adult onset diabetes. You may have heard that too. So about 90% of the people with diabetes mellitus have diabetes mellitus type 2 or DM type 2, and the pancreas still makes some insulin. So some symptoms occur over a long time, and many people are not aware that they have the disease until long-term complications begin. When you see those signs and symptoms, the patient will come in, feel breath and so forth, what I explained to before. So, so the American Diabetes Association, you can also go in and review this. It's you go to diabetes.org and we go over a lot of information with you in regards to diabetes mellitus type 1 and also type 2 and the different types of drugs and medications that can be used. So now drugs that can be used, okay? And okay. So you have the non-insulin anti-diabetic drugs, but just going back here, it shows you like what happens with the pancreas when it comes to the type 1 and type 2, about the pancreas not producing insulin at all, so the pancreas just producing only a small amount releasing a small amount of insulin. So non-insulin anti-diabetic drugs, excuse me, Hmm, Sorry about that. Thank you. So non-insulin anti-diabetic drugs. So patients with diabetes mellitus type 2 usually have a pancreas that functions a little bit and can be stimulated by drugs to produce some more insulin. So drug therapy can also improve how well insulin interacts with its receptors. And insulin may also be necessary for some people who do have type 2 diabetes. But one of the main things that the doctor tries to do first is weight, weight reduction, diet. That can probably help for the patient to not have to take insulin at all. So you have the drugs. You have the non-insulin anti-diabetic drugs are oral, and also injectable drugs that use a variety of mechanisms other than binding to insulin receptors to help lower the blood glucose levels back to their normal range. Um, and at one time, you probably heard the phrase of oral hypoglycemic agents, although that term was really, never correct, because you have some not drugs that just not always oral. You have the injectable ones. But the main goal of drug therapy for diabetes type 2 is to keep blood glucose level within the normal target range for each person, and not to make the person basically have low blood sugar or be hypoglycemic. Okay, and basically hypoglycemia itself is a serious adverse effect of some of these drugs. It's not really the desired effect of it, but you don't want the blood sugars to go too low. Okay. And you're going to have your different classes. We call it the monotherapy versus combination therapy. So you have your 6 classes of drugs that we're going to look at. And these are your sulfonylureas, the first and second generations, your biguanides, your alpha glucosidase inhibitors, your meglanides and your thiazolanides diones, and your icretins, so you'll have those. And it's in your book for the memory joggers, the 8 categories of the non-insulin anti-diabetic drugs. And as you would do when you're going through this, it's a lot of information. So I just want to kind of just make it a little bit easier for you, because when you're going through each of these sections for each of these categories of the uses and the classes of the non-insulin anti-diabetic drugs. Look at the adverse reactions, look at the drug interactions, look at those. But your main thing will be looking at your nursing implications to make sure that you're looking at those with the assessment, the health history, renal and liver function, and also sulfur allergies, and also your patient teaching. So as you're going through this. Okay, and okay, so you're gonna have your insulin. So you're gonna have your insulin stimulators. Again, you have table 17.2 in your book that gives you the examples of the insulin stimulators and the biguanides. So again, you want to, it's a huge categories for each of the drugs. With the insulin stimulators, just know the actions on what they do. The drugs that lower blood glucose levels by triggering and releasing preformed insulin from the beta cells. You're going to have your second generations of drugs with this, which would be, one of them would be your glucotrol. You'll see that, your micronase. Also, and then you have another group of drugs that go with this that falls under the insulin stimulators, which is your meglionide analogs. So your doctor may order your aprandin for that. But again, you have your specific nursing implications that falls underneath all of these. And also under your insulin stimulators and your biguanides, you have metformin. Okay. Now with the metformin, this is a very common drug that you're going to see, When it comes to the nursing implication, when it comes to the metformin, it's two things you want to make sure that you definitely know, especially when it comes to your state boards. You want to check with the healthcare provider about stopping the drug 24 hours before and 48 hours after a drug, 48 hours after a test using a radioactive dye is scheduled. So to reduce the risk of interaction that can cause kidney damage. So any patient that's going to have any type of, like sometimes when you do a CAT scan, they want to probably give you the radioactive dye for that. So you want to make sure, one of the questions they always ask, are you on any medication? Are you diabetic? Are you taking metformin? So that's one of the things I usually ask. Teach patients, okay. Teach patients not to cut, crush, or chew the extended release capsules to prevent rapid absorption of the drug that could lead to adverse effects. Okay, so again, you want to make sure your nursing implications when it comes to, when it comes to those particular generations, that category of drugs. Okay. Then you have your other group of drugs. Okay. Your biguanides. When it comes to the biguanides, again, your planning and implementation. Again, that was the metformin that we were talking about. So that falls under the category of biguanides. So you want to make sure that you're actually looking and assessing the patient for any type of kidney function and kidney failure. Metformin should not be given to patients with any type of kidney disease because it can cause kidney failure. And again, you're going to assess for signs of lactic acidosis and report any concerning findings to the healthcare provider. Also, you want to check the patient's blood sugar as ordered and assess the patients for signs of hypoglycemia. And also, metformin is safe in pregnancy for the treatment of gestational diabetes. Okay. So you have your insulin sensitizers, and you have your group of drugs. And what the insulin sensitizers do, these are drugs that lower blood glucose levels by making insulin receptors more sensitive to insulin, which increases cellular uptake and glucose and the use of glucose. Doctor may order a brand name of drug called Actos or Vandia. Those are some brand name drugs. You want to teach the patient to report indications of allergic reactions such as itching, hives, facial swelling immediately to the healthcare providers when they're on these particular category of medication. Then you have your alpha glutamase inhibitors, and these are non-insulin inhibitors. And this category of drugs, they're non-insulin anti-diabetic drugs that lower blood glucose levels by preventing enzymes in the intestinal tract for breaking down starches and more complex sugars into glucose. And the doctor may order something, one of them is Prandase, is one of the brand names that can be ordered. And here you want to assess the patient for signs of an allergic reaction to the drug. Monitor the patients for hypoglycemia, especially when combined with insulin or other diabetic medications. So you want to make sure that you're looking at that. Okay. Another category of drugs for are your incretin, the Mimetics. Okay. Incretin mimetics. So examples, for that one, these category of drugs, they're non-insulin, they're non-insulin anti-diabetic drugs that act like the natural gut hormones secreted in response to food in the stomach. So they work with insulin to prevent blood glucose levels from becoming too high after meals. This results in an increase in insulin secretion, a decrease in glucagon secretion, and a slower rate of gastric emptying. Um, and again, you want to make sure you review your nursing implications for those. And also the amylin analogs. These are injectable non-insulin anti-diabetic drugs that are similar to natural amylin, which is a hormone produced by the pancreatic beta cells that work with and is co-secreted with insulin in response to blood glucose elevation, and they prevent hyperglycemia by delaying gastric emptying and making the patient feel full so he or she actually eats less. And you'll see what the drug in this category is called pramlintide, and the brand name for that one would be Semlin. And one of the nursing implications will be you want to assess for signs of allergic reactions to this drug. Check blood glucose levels after meal because this is a drug, because this is the drug's time of action and when hypoglycemia is most likely to occur. Okay. When it comes to pancreatitis, this is what I wanted to look at for you. Okay. Okay, so in your book, it talks about a memory jogger with symptoms of acute pancreatitis. Severe upper abdominal pain that radiates to the back, ingestion, nausea and vomiting, bloating and distended abdomen, and also rapid heart rate. So these are symptoms of acute pancreatitis that you can kind of, when your patient, presents those signs. So one of the medications here within the category of the amylin, the amylin analogs, and also to the incretin Memonex, you are looking, when you're doing your nursing implications and also your patient teaching, you want to seek immediate help for severe abdominal pain and nausea that can signal pancreatitis. So you want to make sure that you know the symptoms and the signs and symptoms of acute pancreatitis, which is right here in your book. Okay. Then you have your DPP and your 4 inhibitors. And here you have the non-insulin anti-diabetic drugs that help prevent hyperglycemia by reducing the amount of the enzyme, which inactivates the normal incretins or the GLP and the GIPs. So you have a group of drugs that are here. So again, it's a lot of medication, different drugs. It's a lot of medications. There's a lot of medications here. It's different drugs. So you want to make sure that when it comes to the nursing implications, you can kind of probably just divide it up amongst like the inhibitors and probably what can kind of fall under those categories. But the nursing implications is a lot. And I'm just kind of trying to do like an overview of which ones you might be kind of, more for you to be more familiar with, like for example, the metformin. So again, it's a lot of different medications and it's a lot of different drugs. So again, you want to make sure that you're looking at the nursing implications for the drugs within these categories, what you see, the DPP4 inhibitors and so forth. Okay. your sodium glucose co-transport inhibitors. Okay. Again, you have your patient teachings for that and so forth. That's, you can just it falls under, what is it? It's in your book. Okay, here it is. It's in your book. And so the sodium glucose co-transport inhibitors, these are non-insulin anti-diabetic drugs that lower the blood glucose levels by preventing the kidney from reabsorbing glucose. And again, you're going to be doing it's a lot of nursing implications here too. So you just kind of want to do an overview and kind of break it down a little bit for you to make it a little bit more easier by, you know, I would usually look at the first nursing implications and kind of take it from there because it is a lot. One of the adverse effects when it comes to taking some, when you're taking when you're actually taking a DPP4 inhibitor, you know, patients may present complaints of severe joint pain or, arthralgia has been reported in patients who are taking DPP4 inhibitors. Bullous pemphigoid, a rare skin disease condition that result in a large fluid-filled blisters that are most often occur in the lower abdomen and upper thighs or armpits have also been reported. Figure 17 does show you a picture of the bulbous pemphigoid. So certain things like that you may want to pull out and kind of just add that to like certain things to what you want to observe when it comes to nursing implications and also patient teaching. Okay, so with insulin, just a quick overview of insulin. The best thing for you to know when it comes to this, the tip safeties, the high drug alerts, because this is one of them, because patients, you don't want to give, when you're giving your patient insulin, you're actually drawing it and to actually give it to the patient. So a high alert, and it is a high alert drug. Insulin is a high alert drug that can cause great harm when given at too high a dose, too low a dose, not given to a patient for whom it was prescribed, or given to someone who does not have diabetes. If insulin is given to a patient without diabetes or is given at a high dose, the patient can become severely hypoglycemic, which can result in death. If insulin is given at too low a dose, the patient's blood glucose level is poorly controlled, increasing the risk for severe hyperglycemia, ketoacidosis, and even death. Older patients with poor visions may benefit from a pre-filled insulin syringes, cartilages, or pens to prevent dosing errors. Okay. All right. So I know you have done this in one of your classes, which is Form 1, in regards to actually giving insulin. One of the things, especially when it comes to type 1 diabetes, they have insulin pumps. They have certain systems that can actually be placed onto the patient's skin, and it pumps insulin to them at a certain time, depending on their blood glucose levels. And also in Figure 17.4, it shows you the difference between a U100 and a U50 syringes. So I know you learned this in Form 1, so make sure you do an overview in regards to administering insulin, okay? And your book talks about, here it is, like the insulin pen, the insulin pump, and the different adverse reactions that you can have when the patient is actually taking insulin, like the lipodystrophy, the local itching, the swelling, erythema, um, hypoglycemia, if you're taking a patient's blood glucose level, if it's less than 60, and also do an overview of the certain drug interactions that the patients may have. And, so table 16, 17.4 gives examples of the commonly used types of insulin. So this is really great for you to have, a lot of places have it, so you can actually look at it when you're actually giving your patient insulin, so you can know exactly what you're giving. But you're going to need this for your boards, state boards, when you're actually doing this. So examples of the commonly used types of insulin: you have your rapid acting, your short acting, your intermediate acting insulin, and your long acting insulin analogs. Be sure to look at this because it has the different brands, but the most important is going to be the onset, the onset hours, the peak hours, and also the duration hours and when to give it. So you make sure that you definitely look at this because I know you went over this in Farm 1, so you want to make sure that you're doing an overview of how to give insulin. Okay. And what else you have here? Okay. And your skill sets, mixing 2 types of insulin in 1 syringe. So you want to make sure that you're actually know that in the different subcutaneous injection sites. So make sure you do an overview of each one of those. Okay. Again, so I mean, you will have to go back to your Farm 1. And here is box 17.1, steps to teach patient how to self-inject insulin. So you go through those steps, and that'll help you too because this is part of your part of patient teaching. Okay. So, thank you.